Good evening, Dr. Phil here. Today we'll be discussing on peripheral nerve stimulation in peripheral nerve blocks. Background. There are two types of peripheral nerve stimulator, those that are used to assess the degree of neuromuscular blockade and those used to identify the location of peripheral nerves to aid accurate needle placement in regional anesthesia. Peripheral nerve blocks were initially performed by surgeons under direct vision. Subsequently, peripheral nerve blocks were performed blind, using surface landmarks to guide percutaneous approaches. In the 1960s, electrical peripheral nerve stimulation was developed to aid in nerve localization. Although ultrasound-guided peripheral nerve block is now commonplace, peripheral nerve stimulator is still useful for supplementary confirmation of needle placement, as a safety device to monitor for needle-nerve contact, or intraneural needle tip placement to minimize the risk of nerve damage or intraneural injection. Electrical principles. Peripheral nerve stimulators aim to deliver adequate electrical energy to motor nerves, to reduce the resting negative intracellular potential across the nerve cell membrane, to reach the threshold level and unleash an action potential. This energy is delivered as a monophasic square wave impulse. Many combinations of strength and duration can elicit an action potential. Real base is the minimum current in milliamperes required to initiate an action potential in a nerve at infinite duration. Chronaxy is the duration of current stimulus required to elicit an action potential in that nerve at twice the real base. This is a strength versus duration curve for mammalian, motor and sensory nerves. Stimulation of twice real base current for enough time, i.e. chronaxy, triggers an action potential. Different nerves have different chronaxy and thus different excitability. For example, for A alpha fiber, chronaxy is 0.05 to 0.1 millisecond. For A delta fibers, chronaxy is 0.15 millisecond. For C fibers, chronaxy is 0.4 millisecond. The most efficient way to stimulate mammalian nerves is to use impulse durations close to the chronaxy of the target nerve. For motor fibers, it is 0.1 millisecond, and for sensory nerve fibers, it is 1 millisecond. To stimulate motor fibers only without eliciting pain, the duration of the peripheral nerve stimulator pulse can be adjusted to keep it above the normal A alpha range and below the A delta and C fiber level. Polarity of electrodes. The negative electrode should be attached to the stimulator needle rather than the positive electrode, as only 25% of the current is needed to trigger an action potential in the nerve were the polarity be reversed. Less current is needed due to the negative resting potential of the neurons and the manner in which electrons flow through the nerve with stimulation by a cathode. The current flow towards the needle produces an area of depolarization which readily triggers an action potential. If the positive electrode is used, the current produces a zone of hyperpolarization immediately around the needle tip, with an area of depolarization encircling it. Distance versus energy. Coulomb's law, also known as inverse square law, states that the minimum current needed to stimulate a nerve is directly proportional to the square of the distance from that nerve. If the distance between the needle and the nerve is halved, the stimulatory current will be reduced to an eighth. No responses can be observed until the needle tip is very close to the nerve. The amount of energy required for a response reduces rapidly as the nerve is approached, thus providing accurate distance information. Setting a current of 1 milliamp, motor response is first observed when the needle is 5.5 millimeters plus minus 1.5 millimeters from the target nerve. Features of a modern peripheral nerve stimulator. Constant current output. A modern PNS is able to maintain constant current despite changes in resistance. The needle encounters varying resistance ranging 1 to 20 kiloohms as it penetrates tissues of different density. When the device delivers a constant voltage, the current could vary 20-fold. The output generated is linear, easily varied, monophasic, i.e. flows in one direction only, and can be set in frequency, pulse width, and current in milliamps. It has a rectangular waveform. It has a display which is clear and accurate to 2 decimal places. It indicates the actual current delivered to the patient rather than the target current. Current range typically 0.1 to 6 milliamps to alert intraneural needle placement. Some designs has a higher output range of up to 80 milliamps for epidural stimulation tests, which range typically 1 to 10 milliamps. It has a variable pulse width. The shorter the pulse width, the greater the change in stimulation strength as the needle advances. Short pulse widths such as 0.04 milliseconds provides better discrimination of the distance between the needle and the nerve based on changes in current. With short pulse widths, a large difference in the stimulating current is present when comparing direct contact of the needle with the nerve versus a distance of 1 cm between the nerve and the needle. The typical settings for motor-peripheral nerve: pulse width is 0.1 millisecond, threshold current, avoid less than 0.3 milliamperes. For epidural space, pulse width is 0.2 millisecond, threshold current is 1 to 15 milliamperes. For intrathecal space, pulse width is 0.2 millisecond, threshold current is less than 1 milliamps. Long pulse width, such as 1 millisecond, regardless whether the stimulating needle is in direct contact with the nerve or 1 centimeter away, there is little difference in the current required to stimulate the nerve with long pulse widths. The typical settings for epidural space: pulse width is 1 millisecond, threshold current 6 milliamperes. There are marked polarity of electrodes. The cathode is chosen as the stimulating electrode as it is 3 to 4 times more effective than the anode at depolarizing the nerve membrane. Variable pulse frequency. Modern peripheral nerve stimulators has the facility to alter the frequency of the stimulus delivered. Optimal frequency of the electrical pulse 0.5 to 4 Hz. Typically 2 Hz is chosen. The lower the frequency, the slower the needle should be advanced to avoid missing the nerve between stimulations. Disconnect and malfunction indicators. An indicator which provides a change in tone or light shows the integrity of the electrical circuit. Battery level indicator is essential as well. Peripheral nerve stimulators has been used to guide an insulated needle with an uninsulated tip into the trachea for airway LA injection. Electrical impedance monitor displays the total impedance between the needle tip and the ground electrode. Impedance varies with changes in tissue composition. For example, intraneural space has more lipid and less water content than extraneural space. An increase in impedance greater than 4.3% may indicate intraneural needle placement. PNS are battery operated for patient safety, has robust design. Other accessories may be present, such as surface nerve mapping probes or remote hand control or foot pedal, to allow a single operator to adjust the current output of a nerve stimulator without an assistant. Nerve stimulator needles for single shot blocks. They may be insulated or non-insulated. Most needles are insulated with a Teflon coat apart from the uncovered tip. Insulation of the shaft maximizes current density at the tip. This ensures the distance-energy relationship reflects the position of the tip of the needle in relation to the target nerve. Non-insulated needles can also be used effectively. The current density remains greater at the tip of the needle than down the shaft. However, false positives are more common than insulated needles as nerve stimulation can occur at the level of the shaft. Extension tubing is usually present pre-attached. With a Luer lock type connection, leakage of LA or air on aspiration can occur if connection with the syringe is loose. Extension tubing enables aspiration and injection of LA, normal saline or dextrose 5. There is a female type attachment to connect to the nerve stimulator. Needle tip design can be short beveled, long beveled, or blunt. Short beveled needle causes less nerve damage by being less likely to cut or penetrate the nerve. Greater injury can occur if the nerve or vesicle is penetrated compared to a long beveled needle. Long beveled needles are sharp and more likely to penetrate the perineurium and cause vesicular injury than short beveled needle, particularly when the bevel is transversely oriented to the nerve fibers. There is less injury if the nerve or fascicle is penetrated due to the clean cut produced. Long bevel needle produces less appreciation of fascial planes. Blunt needles are non-cutting. There is better feedback when penetrating fascia. Fascial puncture requires increased applied pressure, and the needle can overshoot after puncturing the fascia, potentially damaging structures beneath the fascia. There is increased post-traumatic inflammation, increased myelin damage, and increased incidence of intraneural hematoma. Length of the needle. Choice of needle length depends on the depth of the target nerve to be blocked. Ultrasound can help with determining the distance to the nerve and needle length required. Common lengths includes 30, 50, 90, 100, and 150 mm. Depth marking helps with monitoring the depth of penetration. Choosing the correct length is important, as a needle that is too short is unable to reach the target nerve, and a needle that is too long is difficult to maneuver and may advance too deeply and risk tissue damage. Needle gauge. Most are 22 gauge. Larger gauges may be needed for longer needles to provide adequate rigidity and reduce bending during maneuvering of the needle. However, there is increased risk of tissue injury or hematoma. Smaller gauges increase the risk of intravascular placement of the needle tip. There is increased resistance on injection of LA and increased time for blood to be aspirated back if the needle tip is intravascularly located. Echogenicity. Mechanisms to improve visibility of the needle during ultrasound-guided peripheral nerve block has been developed by increasing reflection of ultrasound beams, either by using a special coating that traps micro air bubbles, grooves near the needle tip, or echogenic dots made by the cornerstone reflectors. There is decreased time to visualization of the needle under ultrasound guidance and allows the needle to be visualized clearly even at a steeper angle. Practical conduct of peripheral nerve blocks with the aid of peripheral nerve stimulation. Anesthetic assessment. Obtain history, examination, and investigations as indicated. Obtain patient consent. Indications for nerve blocks includes avoidance of GA, such as in patients with poor health, risk of post-op nausea vomiting, or desire for early discharge from hospital. To achieve early return to normal diet, especially in diabetic patients. For post-op analgesia, which allows effective physiotherapy. Improvement of blood supply to the surgical area. To achieve early mobilization of the operative area, such as tendon repair surgery. Contraindications for nerve blocks. Absolute contraindications includes patient refusal, infection over needle puncture site, and local anesthetic allergy. Relative contraindications includes coagulopathy, general sepsis, uncooperative patients, and peripheral neuropathy. Choosing the appropriate peripheral nerve block. For carotid surgery, superficial cervical plexus block or deep cervical plexus block. Thyroid surgery, bilateral superficial cervical plexus block. Shoulder and upper limb. Shoulder surgery, interscalene block. Humerus surgery, interscalene block. Elbow surgery, supraclavicular, infraclavicular, coracoid or axillary block. Forearm surgery, choices of PNB as with elbow surgery, with other choices including mid-humeral block, elbow block, forearm blocks, and IV regional anesthesia. Hand surgery, choices of peripheral nerve block as for forearm surgery, plus wrist blocks. Ensure adequate peripheral nerve block coverage for areas where tourniquets are applied. Trunk and abdomen. Thoracotomy. Options includes thoracic epidural, thoracic paravertebral blocks, intercostal blocks, erectospinal plane block. Rib fractures, choices of PNB as with thoracotomy. Major breast surgery, thoracic epidural, thoracic paravertebral, erectospinal plane block, PAX 1 and 2 block. Upper abdominal surgery, thoracic epidural, thoracic paravertebral, ESP block, TAP block. Laparotomy, epidural, TAP, rectus sheath or ESP blocks. Lower abdominal surgery, subarachnoid block, epidural block, erectospinal plane block or TAP block. Inguinal hernia repair, ilioinguinal plus iliohypogastric nerve block, subarachnoid and caudal block. circumcision, penile and caudal block, hemorrhoid surgery, saddle block, or local infiltration of local anesthetic. Lower limb, for hip surgery, subarachnoid block, epidural, CSE, femoral nerve block, fascia iliaca block, lumbar plexus block, lateral cutaneous nerve of the thigh block. Above knee amputation, subarachnoid block, epidural, combined spinal epidural, lumbar plexus, sciatic nerve plus femoral nerve block. For knee surgery, subarachnoid block, epidural, combined spinal epidural, or sciatic nerve plus femoral nerve block. Leg surgery and ankle surgery, choices of PNB as with knee surgery. For ankle surgery, popliteal sciatic and saphenous nerve block. Foot surgery, ankle block, or choices of PNB as with knee surgery. Ensure adequate PNB coverage for areas where tourniquets are applied. Setting up the peripheral nerve stimulator for peripheral nerve blocks. Ensure adequate battery power, functioning cables and connections properly placed, machine displays current actually flowing to the patient, display visible to the operator. Either the needle should be moving or the current should be changing, but never both at the same time. Avoid muscle relaxants. To reduce discomfort when blocking the awake patient, ensure careful control of needle speed. Stimulate motor fibers only without eliciting pain by setting the duration of the PNS pulse to 0.05 to 0.1 millisecond. Initial injection should be done slowly. Performance of the block. Full resuscitation facilities should be available, full monitoring according to AAGBI standards, personnel available, anesthetist, assistant, person to provide emotional support to the patient. Equipment, ultrasound, resuscitation drugs including intralipid, nerve stimulator, insulated short bevel needle, oxygen supply, local anesthetics and additives, calculate required dose and do not exceed the maximum local anesthetic dose, etc. Confirm the consent and site of the block. Sedation with midazolam, fentanyl. Aseptic technique. Don hat, mask, gown and gloves. Prepare skin with 0.5% chlorhexidine in 70% alcohol and wait until the skin is dry. Drape the patient. Analgesia should be provided, such as fentanyl and subcutaneous injection of 1% lidocaine at the point of needle insertion. Technique can either be ultrasound guided or landmark technique with or without nerve stimulator. Threshold current. Various techniques exist. Some anesthetists start with a relatively high current of up to 2 milliamps. Others use current less than 1 milliamps. At a current of 1 milliamp, motor response is first observed when the needle is 5.5 millimeters plus minus 1.5 millimeter from the target nerve. The current should be reduced to 0.5 milliamp as the needle approaches the target nerve. The needle tip is 1 to 2 millimeters from the nerve if motor response is seen at 0.5 milliamps. If motor response is seen at 0.2 milliamp or lower, the needle may be intraneural and should be repositioned. Under ultrasound guidance, it has been demonstrated that a needle may be in close proximity to a nerve, but yet a current of more than 1 milliamp will elicit no motor response. Avoid intraneural injection to reduce risk of nerve trauma. A quick recap on the classification of nerve injury. There are few classifications. For Sedon classification, neuropraxia corresponds to Sunderland 1, axonotmesis corresponds to Sunderland 2, neurotmesis corresponds to Sunderland 3, 4, 5. For neuropraxia, myelin damage, typically from nerve stretching or compression, occurs. Endoneurium, perineurium, and epineurium are intact. Conduction slowing and blocking occurs. Prognosis is good. Complete recovery of function within weeks to months can be expected. Most neurological injuries following peripheral nerve blocks tend to be neuropraxic in nature. For axonotmesis, there is loss of axonal continuity. Mechanisms include fascicular impalement, nerve crush, or toxic injury. Endoneurium is intact. There is no conduction. Prognosis is fair. Recovery is prolonged and variable. For Sunderland stage 3, which corresponds to neurotmesis, there is loss of axonal and endoneural continuity. Perineurium is intact. There is no nerve conduction. Prognosis is poor. For Sunderland stage 4, There is loss of axonal, endoneural and perineural continuity, epineurium intact, no conduction, prognosis is poor. For Sunderland stage 5, complete nerve transaction, no nerve conduction, prognosis is poor. Neurotmesis typically requires surgical repair. Proximal axonal lesions are more severe than distal axonal lesions. To avoid intraneural injections, use of ultrasound guidance can help to detect intraneural injection. However, detection of intraneural injection by ultrasound imaging may be too late, as injection of only a small quantity of injectate can rupture a vesicle. Current ultrasound technology is unable to provide adequate resolution to differentiate intervascular and intravascular needle placement or injection. Adequate imaging of the needle-nerve interface is also affected by operator skill and patient anatomy. Avoid excessive needle passes or injections. Reposition the needle if contractions occur at less than 0.2 mA during nerve stimulation with an impulse duration of 0.1 millisecond. Reposition the needle if opening injection pressure is more than 15 psi. Only use one time to inject gently. Injection should be easy with low resistance. Use short bevel needles. Observe the patient for pain or abnormal movements. The presence or absence of paresthesia during needle positioning or during injection of local anesthetic does not predict nerve injury reliably. Low intensity dull ache during local anesthetic injection can be regarded as a normal response, also known as pressure paresthesia. Injection should be stopped if the patient complains of severe pain during needle advancement or injection of local anesthetic. In anesthetized patients, signs of pain includes limb movement, laryngospasm, and sympathetic response. Injection should be stopped if these are present and needle repositioned. As a summary, give bolus, observe and reposition the needle and repeat. Twitches should disappear immediately on starting injection. If the process of peripheral nerve block gets weird, stop. Better a failed block than nerve or organ damage. Injection. Twitches should disappear on injection. Injecting a small amount of local anesthetic or water or air abolishes the twitch by physical displacement unless the needle tip is intraneural. Caveats: conductive solutions such as local anesthetic and saline will stop the twitch. Non-conductive solutions will not stop the twitch, such as dextrose 5% actually enhances the twitch. Conductive injectate emerging from the needle tip effectively increases the size of the needle tip and reduces perineural electric field and thus abolishes the twitch. Clinical implications: the needle should be repositioned if the twitch does not disappear on injection of LA. Use 5% glucose as injectate when placing stimulating catheters, as 5% glucose will not interfere with stimulation responses. Premature injection of LA prior to reaching desired needle tip position can impair the ability to locate a nerve accurately. Blood is highly conductive, thus blood at the needle tip region can abolish expected twitches. Reposition needle if opening injection pressure exceeds 15 psi. Nerve damage during peripheral nerve block can result from mechanical and injection injury, vascular injury, neurotoxicity from chemicals, and inflammation. High initial injection pressures are associated with permanent neurological damage, as the needle tip might be intravascular. Initial injection pressures: it is low, less than 4 psi if perineural, moderate, less than 10 psi if the needle tip is intervascular. It is high, more than 20 psi if the needle is intravascular. It is more than 15 psi if there is nerve-needle contact. Thus, intraneural needle insertion may not always lead to nerve injury due to subepineurial injection with no vesicular damage. Injection into loose perineural connective tissue should never require more than 15 psi. High initial pressures can be followed by a drop in pressure after vesicular rupture. Devices are available commercially to measure line pressure during LA injection, such as this inline pressure manometer. If inline pressure manometer is unavailable, the compressed air injection technique developed by Sui can be used. Boyle's law dictates at constant temperature, pressure times volume is a constant. At constant temperature, pressure will increase from 1 to 2 atm if volume of a gas is reduced by 50% in a closed container. Firstly, aspirate a set amount of air above a volume of injected within a syringe. Then compress the volume of air to maintain it at a certain percentage during injection. At 50% air compression, the injection pressure was less than 15 psi. Benefits of CAIT: ensures injection pressure is always less than 15 psi throughout the injection, less risk of nerve injury. There is reduced speed of injection, and this reduces the risk of intravascular injection or injecting LA into unwanted tissue planes. There is decreased high peak pressures throughout the injection period. Successful peripheral nerve block. If using peripheral nerve stimulator to locate target nerve, aim to attain location 2 to improve nerve block success. There are 4 possible locations of the needle tip prior to LA injection. Outside epineurium and fascial layer, muscle twitch is unstable at more than 0.5 mA, opening injection pressure less than 4 psi, nerve blockade usually fails, there is no nerve damage. When the needle tip is outside epineurium and within the fascial layer, muscle twitch is stable at less than 0.5 mA, opening pressure is less than 4 psi, nerve blockade is successful and there is no nerve damage. If the needle tip is inside the epineurium, muscle twitch is excellent and may be triggered by currents less than 0.2 mA, opening injection pressure is less than 10 psi, nerve blockade is successful and there may be prolonged nerve blockade, nerve damage is possible. If the needle tip is inside the perineurium, muscle twitch is very vigorous at less than 0.2 mA, opening injection pressure is high, more than 25 psi, nerve blockade is probably successful, nerve damage is highly likely. Seeing LA spread around a nerve under ultrasound is the best indicator of a successful block. Failure rate of PNB using peripheral nerve stimulation solely for nerve location ranges 5 to 50%. Causes of failure of PNB: anatomical variations, needle mislocation, bevel of needle may not be within the fascial plane containing the nerve, blockade of motor rather than sensory fascicle or vice versa within a mixed nerve can occur, poor anatomical knowledge, poor technique, wrong drug, wrong volume or concentration of the drug, pre-existing neurological impairment, plexus septae or scar tissue. Intraoperative management: test for sensory and or motor block prior to inflation of tourniquet or surgical incision, full monitoring as with general anesthesia, beware of local anesthetic toxicity, separate the patient from the surgical site with a screen, provide sedation, check the patient regularly for pain or discomfort. Always be prepared to convert to general anesthesia or abandon surgery should LA fail. Post-operative management: protect the operation site from injury, provide arm sling for a limb with residual motor or sensory block. Adequate preloading of analgesia, provide information to the patient on the timing of return of sensation and motor function, provide contact information to the patient for any queries. Patients with complications that may be due to nerve blocks should be reviewed by the appropriate specialist. These are my references. Thank you.